Our next presenter is Professor Alan James. And Professor James trained and practices as a consultant respiratory physician at Sir Charles Gairdner Hospital and the Hollywood Private Hospital with an adjunct appointment at the University of Western Australia. As a physician and a scientist, his clinical interest includes airway diseases, including asthma, COPD, and cough, and respiratory disorders of sleep. And he has two broad fields of research interest: airway structure and function, and epidemiology of lung diseases. He chairs the Busselton Population Medical Research Institute. He's currently the principal investigator on two NHMRC-funded projects: heterogeneity of airway remodeling, which will develop a new method of measuring airway smooth muscle in people with asthma, and the phenotypes of airway disease, which will develop algorithm for diagnosis and management of airway diseases in primary care. He has over 250 publications, and he was awarded the Thoracic Society of Australia and New Zealand Research Medal in 2020. Welcome, Alan.
In the short time available for the rest of my talk, thank you very much, and I'd like to thank the organising committee for asking us to come along and present our work today. I should point out that the Busselton Health Study, which you'll see featured heavily in the logos, is already a very strongly collaborative organisation. It's a collaboration between PathWest, UWA, Departments of Health, Curtin University, Department of Jobs, Tourism, Science and Innovation, Edith Cowan University, Murdoch University, WAHTN, the Australian National Phenomics Centre, and our numerous national and international collaborators, including the Busselton population, who've been involved in the Busselton study since 1966. I have no conflicts to declare, other than I'm not a mental health expert. So this, in 2020, the peak of the COVID cases occurred in WA on the 29th of March, with 403 cases recorded. COVID-19 control measures were enacted in April and May 2020, and these included stay-at-home orders, physical distancing, closure of recreation facilities and non-essential business, cancellation of elective surgery, limits on dispensing and sales of prescription and over-the-counter medication, and purchase limits on staple food items and takeaway alcohol. By mid-June 2020, many restrictions had eased, but the control measures and the presence of the epidemic included a pause in research, and that involved, as many speakers have mentioned, various programs of research, including our research in Busselton. This left a number of researchers idle with a research infrastructure all ready to go, so that when we received the grant to study the effects of mental health, we were ready to start straight away with a research team. So we took on a study to look at the mental health effects of the COVID-19 epidemic and the control measures on a previously studied general population. And the unique feature of our population was that it had already been studied on two previous occasions with extensive phenotyping and blood measures and physical measures taken on this population. So it was a good opportunity to look at the effects of the change in behaviour and the imposition of the epidemic on people. So, as I said, there were the Busselton Health Study, the Busselton Healthy Ageing Study, from where we took our sample, started in 2010 with extensive characterisation of the population. 3,000 of those individuals had been followed up by 2020, repeating the same measures, including mental health measures, and the particular study that the survey involved recalling those individuals. We were able to obtain results on 2,260 people returned, and that left us with 1,670 who had attended all three surveys, and they formed the basis of these results. So the demographics of the individuals, as recorded in 2020, this is a healthy ageing study. They were all 46 to 64 years old at the time of initiation of the study, and they are now 55 to 74 years old. 60% women, 53% retired, 70% owned their own home, and the income prior to the pre-pandemic, as you see recorded there. Most dwellings had 2 people living in the house, and during the pandemic, we see that 30% of individuals had a reduction in their income. The impact of COVID-19 was measured. Obviously, not a direct impact, because no members of the Busselton Healthy Ageing Study had contracted COVID-19, and very rarely had it involved their immediate family or other people they were related to. 14% of the group had to work or study from home during the pandemic. 8% temporarily lost their job due to the COVID-19, and 5% were either laid off or had to quit their job because of COVID-19, and 26% it affected a family member in terms of their level of work. There tended to be more people at home, and the largest effect was actually changing plans to attend events or to travel, affecting 77%. We asked people how concerned they were about their COVID-19, and how worried they were about either contracting it, family members contracting COVID-19, affecting their daily tasks, changes and restrictions due to the COVID-19, excuse me, and how concerned were they about the long-term effects. And you can see, particularly in terms of contracting or a family member contracting the disease, or the long-term effects were the major causes of concern to members of the community. The predictors of how concerned people were, the individual predictors, were whether they had increased anxiety scores from their questionnaires, lower senses of well-being, or a higher score for loneliness. We also had developed a score in the past for measures of multi-morbidity from our previous surveys of this group, and the number of chronic conditions at baseline was also a predictor of level of worry. And we have for this group information on other chronic non-infectious diseases. You can see there that depression and anxiety is pre-existing in a large proportion of this population, which reflects general population prevalence. Most people had about 3 chronic conditions recorded. We asked them about what behavioural changes were necessary, and these were related to the public health advice, hand washing, social distancing. What else was there? I think they were the main things. And obviously, to what extent did you read the news or get exposed to coverage? And that was pretty impossible to avoid, obviously. Slightly more people, 14% exercise more, some exercise left, couldn't change their drinking habits. More people reported, 20% recorded eating more snacks, and 25% more were focusing on social media. I won't go right through this, but there was an impact on what people did with regards to their general health, and 20% of individuals said that the access to health care was affected by restrictions, mostly related to routine care, non-urgent medications, management by primary care often being cancelled or delayed, and obviously there was an increase in telephone and video consultations. So if we now look at the mental health effects more specifically, so this is the results for depression, anxiety and stress using the DAS-21 score. At the bottom there you can see, I can't point to that. So these are the three different trials, three different studies. The phase 1, phase 2 and the specific COVID 2020 study. And the green line there is the score for anxiety, where there was a slight reduction, if anything, in scores for anxiety. There was no significant change in the depression score or scores for stress, specific domains within the DAS questionnaire. So overall, the levels of stress, anxiety and depression were, the scores were on average normal, with a small decrease, if anything, in stress. In terms of generalised anxiety disorder, the GAD-7 questionnaire, there was a reduction in anxiety for both men and women. That was compared with the Busselton Healthy Ageing Study, phase 1, with no change for men in phase 2, from phase 2, for men or women in phase 2. So again, the score levels were generally normal, with a small overall decrease in anxiety score compared with 2010. And scores of depression severity, the PHQ-9 questionnaire, these look like big changes. However, the scale's relatively contracted there. These changes are not significant and fall within the normal range. And, excuse me, prevalence of diagnosed depression, no significant change again over that period. In multiple regression analysis was a small decrease, if anything, compared with the original study. And lastly, the score for Wellbeing from the Warwick Edinburgh mental wellbeing score. Again, there was a small reduction compared with the second healthy ageing study in men and compared with the original study, and the same result for women. Although these changes reflect possibly just community variation, the overall average score is actually is normal and is in fact better than the Scottish population in which it was derived, which possibly says something about the Scottish population. So in summary, no cases obviously in the population. As an older population who were generally homeowners and about 50% retired. 50% there was presence of multimorbidity, as we've previously demonstrated. There was a reduction in work or an effect on work in about 40% of respondents or their families. There was more people in the home. There were financial difficulties, and events or travel were seriously curtailed, obviously. There was moderate or more concern about contracting COVID, coping with change and long-term side effects or long-term consequences of the pandemic. And these were related to pre-existing illnesses and to mental health conditions. Behavioural change, media obsession, perhaps, washing of hands, social distancing. So people did do what they were asked to do, and there was a slight reduction in the use of non-urgent care and increased use of telehealth. No significant change in the scores of stress, depression and anxiety. A small change in stress, although again I stress that this is only a small change. Anxiety, severity of depression and diagnosed depression, really minimal changes, and some reduction in wellbeing, which may reflect community variation. So we conclude that despite no community cases, this older population was significantly impacted by the epidemic, as I think applies to the whole of Australian population, with regard to changes in work, health, lifestyle and preventive measures. The epidemic was associated with concerns about changes and the potential immediate and future health effects. These concerns were greater though in those with pre-existing conditions, and using standard questionnaires there were no significant changes in diagnosed or in measures of stress, anxiety, depression, diagnosis and severity of depression. There was a reduction in wellbeing, but I think this is not clinically relevant. So the study has some limitations. It's in an older, relatively established population. We may have different results if we were looking at younger individuals, and especially in subgroups, perhaps where there's loss of jobs, complete loss of jobs, and greater financial burden. The magnitude of the effect may be affected by pre-existing depression, which we haven't fully explored yet, and other participant characteristics may also influence the outcome. But it does appear that although people are greatly impacted, or to a large extent impacted by the pandemic and the requirements for differences in behaviour and healthcare modification, it hasn't resulted in this group at least in a rise in significant mental health problems, more of ones of concern. Time is okay. I'll just finish off there by acknowledging the WA Department of Jobs, Tourism, Science and Innovation, the WA Country Health Service, the Department of Health, WAHTN, again thanking them for putting on this wonderful meeting, the Commonwealth Government, the Busselton Community Advisory Committee, the study participants and the people of Busselton. Thank you very much. I should just add, I think this study does show that the Busselton population is a resource where we can take on these population studies at a moment's notice almost, and we stand ready to study the effects of COVID into the future.
Thank you, Alan. I will allow a question. This one for Professor Alan. Welcome.
So perhaps I'll yell out. I was wondering whether you would perhaps with crystal ball gaze and take your study into a population where there was a significant outbreak. Are there examples of studies such as yours that shows a different outcome for stress, anxiety and depression?
Yeah, I can't answer that last part of the question, George, because I'm not a mental health researcher normally, and I'm sure that there have been, I'm pretty sure there are studies that have shown effects in terms of increased depression and anxiety, perhaps a different demographic, but I think that, and they have mainly been in populations where there is a lot of COVID. We hope to take these studies further now that we've got this database, and we can follow up if there is COVID spread into the community, and we can look at the effects of infection. We can also look at the effects of the vaccination in combination with our partners such as ANPC, as Jeremy has mentioned it previously.
Thank you very much. This is your token.
Thank you.
Thank you.